All right, let's dive right into this explainer and investigate what is essentially a chaotic, microscopic crime scene: cellular necrosis. We're going to look closely at what happens when a cell doesn't just quietly pass away, but goes out in a violent, highly destructive biological explosion that leaves an absolute mess behind. To make sense of this dense pathology, we'll follow this roadmap. First, the scene of the crime. Then, the murder weapons. Third, the fatal sequence. Fourth, microscopic forensics. Fifth, modus operandi. And finally, the blood evidence. Okay, let's kick things off with Section 1, the scene of the crime. So the crucial point here is that necrosis happens when cellular damage is just so severe that the cell's repair mechanisms completely fail. It's the point of no return. This results in a violent rupture where the cell loses its membrane integrity, its own internal enzymes digest it, and all those intracellular guts leak out. And that leakage, that's what triggers a massive, messy, inflammatory police response of the surrounding tissue. That inflammation is really the hallmark feature of necrosis. And this brilliantly illustrates the core difference you really need to keep in mind. While apoptosis is a neat, highly regulated cellular suicide where the cell quietly shrinks down, necrosis is an entirely uncontrolled pathological explosion. Moving on to Section 2, the murder weapons. Cells face a lot of severe stresses, things like chemical toxins, think heavy metals or acids, physical agents like burns and radiation, and aggressive bacterial or fungal infections. They can all certainly overwhelm a cell. Even our own immune system can cause necrosis during autoimmune reactions or vasculitis. But pay close attention to that first point, ischemia, which is the deprivation of blood supply and therefore oxygen and nutrients to the tissues, is by far the single most common cause of necrosis in clinical practice. It's exactly what leads to things like myocardial infarctions or heart attacks. Which brings us to Section 3, the fatal sequence. This precise sequence plays out exactly like falling dominoes. First, severe ischemia causes oxygen to drop, which means ATP production just plummets. Without ATP, the cellular pumps fail, and the cell rapidly swells up with water. This leads to a toxic flood of calcium rushing into the cell. Now that calcium acts as a trigger, activating harmful enzymes that start tearing down the cytoskeleton and the cell membrane. On top of that, reactive oxygen species start ripping apart proteins and DNA, and the mitochondria suffer irreversible damage. All of this chaos builds up to the absolute most critical event, the fatal rupture of the plasma and lysosomal membranes. Once those lysosomal membranes break open, their hydrolytic enzymes leak out and literally digest the cell from the inside out. Let's check out Section 4, microscopic forensics. Under a microscope using a standard H&E stain, a necrotic cell looks completely different from a healthy one. Because RNA is lost and the intracellular proteins are totally denatured, the cytoplasm turns intensely pink or eosinophilic. Notice how it takes on this glassy, dense, structureless appearance. It also becomes riddled with vacuoles, literally empty holes left behind by those destructive digestive enzymes. Plus, you'll see myelin figures popping up, which are basically just clumps of phospholipids left over from the shattered cell membranes. And while the cytoplasm is turning pink and glassy, the nucleus is undergoing its own catastrophic breakdown. It follows a highly predictable three-step collapse. Step 1 is pyknosis, where the nucleus shrinks down into a tight, dark blue dot of condensed chromatin. Next comes karyorrhexis, where that shriveled nucleus shatters and fragments into tiny pieces. And finally, karyolysis, where the nucleus just fades and dissolves entirely as it gets digested by enzymes. By the end of the sequence, you're left with a completely dead cell with no nucleus whatsoever. Let's dive into Section 5, modus operandi. Depending on the specific organ affected and the underlying cause of the injury, the resulting dead tissue can look radically different. It can range from a firm, ghost-like structure to a completely liquid, viscous mess, or even chalky white deposits, like what you see in fat necrosis during pancreatitis. Let's take a closer look at a few of the most common types. First up is coagulative necrosis, which is the most common type overall. This usually strikes solid organs like the heart, kidneys, and spleen after an ischemic infarction. What's super fascinating here is that the cellular proteins denature so incredibly quickly that they actually freeze the cell's enzymes before they even get a chance to digest the tissue. Because of this, the cell's physical outline is temporarily preserved for several days, almost like a microscopic fossil. The tissue becomes firm and pale, and under the microscope, you can see the perfectly preserved architecture of the cells just missing their nuclei. But this brings us to a really fascinating exception. If a lack of blood flow to the heart leaves behind firm, coagulative tissue, why does a stroke, which is essentially a lack of blood flow to the brain, result in a completely liquefied, viscous mass? Well, the answer lies entirely in the brain's unique histological environment. Unlike the heart, the brain doesn't have strong, fibrous connective tissue support. Instead, it's absolutely packed with lipids, or fats, and highly active hydrolytic enzymes. So when brain cells die, enzymatic digestion completely overpowers the protein denaturation process. The dead brain tissue simply digests itself, rapidly liquefying into a soft, viscous mass filled with necrotic debris and neutrophils. And we certainly can't overlook caseous necrosis. This is the ultimate hallmark of tuberculosis. Think of it as a combination of both coagulative and liquefactive necrosis. Macroscopically, it leaves behind this distinctive, soft, white, cheese-like material in the tissue. Microscopically, the tissue architecture is just completely obliterated, replaced by a mass of granular pink debris that's tightly surrounded by a wall of granulomatous inflammation. Finally, we reach section 6, the blood evidence. Because the central critical event in necrosis is the shattering of the cell membrane, all of those specialized intracellular enzymes leak right out of the dead cell and dump directly into the patient's bloodstream. Doctors can actually test for these. They act as highly reliable forensic diagnostic markers for specific organ damage. For example, if we see elevated troponin in the blood, we know there's coagulative necrosis happening in the heart muscle. If we see elevated AST and ALT, we know liver cells are rupturing. And high amylase or lipase points straight to enzymatic fat necrosis in the pancreas. This chart really acts as our ultimate takeaway for this topic. It perfectly contrasts the two paths a dying cell can take. On one side, you have the violent, entirely pathological, energy-independent chaos of necrosis, marked by swelling, disrupted membranes, random DNA shredding, and severe inflammation. And on the flip side, you have the quiet, energy-dependent, highly regulated shrinking process of apoptosis, where the membrane stays completely intact and there is absolutely zero inflammatory response. Which leaves us with this final crucial question to think about regarding the future of medical intervention. If we know the exact domino effect of ATP depletion, calcium influx, and membrane rupture, where exactly is our best window to stop the explosion before the damage becomes permanent? Thank you so much for joining this explainer, and keep exploring the incredible and sometimes chaotic microscopic world.